stuff on the medial side as well. This is more sort of looking at the elective pathologies that we see rather than trauma-related stuff. So it doesn't really go into all the instabilities and that kind of thing, although it touches on it a little bit. And the point about elbow pain is that not all elbow pain that we see is tennis elbow, but most patients are referred with this as the diagnosis. Anyone know what that bird is? Yeah, what? A common plover. You've got half a mark for plover. Okay, so it's a surprisingly debilitating condition. And it affects 1 to 3% of the population, that sort of middle age bracket, and it's got a natural history of 10 to 18 months. So I think that's a very important thing to remember, is that it does get better, and you can tell your patients that all these treatment options, most of them get better. 50% of tennis players get the condition, but they only contribute to about 5% of the total population. And in terms of the time frame, 80% are better by 6 months, 90% are better by a year. So it's important just to reassure your patients that if they can deal with the pain, if you can manage the pain, it does get better. ERCB is the most commonly involved tendon, and this is a tendinosis, which is degenerate rather than a tendinitis, which is primarily inflammatory, although it can start at that. There are lots of different theories as to how this develops, but the sort of more commonly accepted progression is that with repetitive overuse, you get these micro tears within the tendon, and as these accumulate, there's an impaired healing response that leads to degeneration of the tendon. And there are these histological stages that are documented with an initial acute inflammation, and then this angiofibroblastic hyperplasia and hypercellularity. Then you get loss of collagen continuity and a buildup of type 3 collagen, and then the associated features that are sometimes seen with fibrosis and calcification, which you may see within the tendon.
Who described that change? Inertial acute inflammation, collagen changes, tears, and then calcification and
Inertial. I just have Maury every time you hear elbow. It doesn't work like that. Sometimes it's a Driscoll. Okay. But there are a lot of other pathological components which can contribute to the development of degeneration of the tendon. There can be avascularity of the tendon. So the theory is that with repetitive contraction, you get an impairment in the vascularity of the tendon. That avascularity causes degeneration. Local hypothermic injury, stress shielding, which results in shear forces between the collagen rather than tensile forces. And then there's probably also a genetic predisposition. But none of these factors really explain the variability in the severity of the pain. And you get patients coming in who literally cannot lift a cup of tea. They're so painful. And there's nothing really that we know that explains that. So the theory is that there may be an increase in the neurotransmitters like glutamine or local irritation by lactate, which causes an increased sensitization of the nervous system, which causes this heightened pain response. The clinical history is fairly similar with most patients. There's pain over the lateral side, and they often point to the lateral epicondyle. There may often be a history of a minor injury or overuse, bumping the elbow in the doorway as you walk through and then saying it never settles down after that. That's sort of fairly classic. Or one of my patients said the other day, he played 8 rounds of golf in 9 days, and it's painful. I don't know who gets to do that, but that was his cause. And there can be quite a diffuse radiation of the pain from the elbow. So it can radiate down into the forearm and wrist, up into the upper arm, and some patients even complain of neck pain related to that tennis elbow, aggravated by gripping and lifting, particularly in pronation. So the classic is a sort of pouring of the kettle that brings it on. And it's often more difficult in the morning. They have stiffness and difficulty with extension of the elbow in the morning. You examine these patients as with anything in the upper limb. You always screen the neck, you always screen the joints upstream, so do a shoulder screen. And on palpation, they are point tender over that lateral epicondyle. They usually have a full range of motion, so it's not something that causes stiffness. pain is bad enough, then the pain is going to stop them going into full extension. So they may have a limitation in their range caused by pain, but there's not a physical block to. Cousins test. It's a provocative test for the common extensor. So with the elbow in extension, you do wrist extension. So pronated and extended with the elbow in extension is more sensitive. And Maudsley's test, which is the resisted middle finger in extension. I find that Cousins test much more sensitive anyway when I examine the patient.
What's Maudsley's test? What other condition gives a problem?
No.
Yes.
So there's a lot of interaction between these tests, and I think the important thing is it's the same with all the examinations that we do. If you're performing a provocative test, it must reproduce the symptoms that you're looking for. So there's no point in doing that and they scream with pain, but they're saying it's medial sided. It's got to localize to that lateral epicondyle. And the same with Maudsley's test. The extensor grip test, so similar to Cousins' test, resisted wrist extension, but when you apply pressure over the common extensors just below the epicondyle, the pain is relieved. So in a similar principle to those counterforce braces that they use. So you may get some relief of the pain. And then obviously the injection test. So inject local anesthetic, usually with cortisone into that spot. If the pain goes away, it's much more likely that that's going to be your diagnosis. Investigations, you usually don't need a whole lot of investigations. This is a clinical examination, but they can be useful if you're trying to rule out other pathologies or if there's diagnostic uncertainty. So maybe a patient who doesn't respond well to a cortisone injection, or if the pain is very diffuse, or you think maybe there's something else going on, then your investigations might help to rule that out. And then you go through the usual list of bloods, x-rays, and imaging. The important thing is that with all your imaging studies, they don't take the place of good clinical judgment, and they don't always correlate well with clinical symptoms, particularly when you're starting to look at MRI scans. MRI is a very sensitive tool, but the number of times that you do an MRI looking for something else and it shows that there's tennis elbow and the patient's absolutely asymptomatic from that point of view, we often see. You use your imaging studies cautiously when you it is a clinical. So the treatment, there are lots of different treatments in tennis elbow, and it can start with anything from simple modification. And there was a study that showed 52 weeks of activity modification is the same as cortisone. The natural history is 52 weeks, isn't it? So it's essentially benign neglect, it's going to get better. So it's just telling you that it does have this natural history, and that cortisone maybe doesn't change the natural history of that. There were studies that showed that physio is better than benign neglect at 6 weeks. And the physio that we're looking for here is not all the needling and massage and stuff that the physios do enjoy doing, but you specifically look at stretching, range of motion, and then as the pain is settled, eccentric loading exercises. So stretching, loading the tendon under stretch, so as it's going down. Anti-inflammatories, diclofenac was better than placebo in the short term. Cortisone better than diclofenac at 4 weeks. So these are all various studies that looked at different treatment options. And bracing, a meta-analysis showed no superiority of one brace over another, wrist or counterforce braces. So I tend to go through all of these options with the patients and see which one works for different patients. Some of them do get a lot of benefit from those counterforce braces. Some patients have one cortisone injection and that's it, they're sorted. So I think that the relative harm of these treatment options is fairly low, although you do have to warn them about the cortisone injections. Firstly, the local complications of skin thinning and depigmentation. And when you give the injection, you must tell them that they're going to kiss you in a couple of hours' time, okay? Because they can be very painful. All right. There are lots of other alternative treatment options that have been tried. Radiofrequency, extracorporeal shockwave therapy, laser, acupuncture, Botox, nitrates, autologous blood, platelet-rich plasma. So all of these, you can find studies which will support the use of these, but you've got to read into those studies a little bit more. And when you see all these different treatment options reported, you know that there's no silver bullet. Okay. This was a systematic review, meta-analysis looking at non-operative treatment of lateral epicondylitis. And they showed that the highest quality evidence does not support the use of physio, cortisone injections, PRP, or autologous blood. So when you look at these big meta-analyses, you can't show the difference. Review does not support the use of autologous blood or PRP injections for lateral elbow. So the summary of the non-operative treatment is that there are numerous non-operative treatment options, none of which are successful enough to warrant general recommendation in a condition with a natural history of 10 to 18 months. So essentially, you're trying these treatment options that have relatively low side effect profiles. There's little harm in trying them, and different ones are going to work differently for different patients. Our usual approach is to start the patients with anti-inflammatories, pain medication to try and minimize it, get them to a physio to try and do some stretching exercises. If they're not tolerating that, a cortisone injection, and you try and sort of nurse them through like that. I tend not to use PRP, although I know that there are quite a few. When it comes to surgery, there are lots of different surgical options. So open surgery has got about 90% good to excellent results in this study. Open surgery, again, within that open surgery group, there are lots of subtleties and variations in how you do it, and most of them involve a longitudinal incision and then varying degrees of release of the annular ligament, release of the common extensor tendon, decortication of the underlying bone, and then repair. So you will see procedures that go from sort of opening it up, giving it a bit of a scratch and putting a vicryl in, to procedures that take the whole thing down and put in an anchor and suture it up. And there really aren't any good studies to show that one open technique is better than the other. Complications, hematoma, wound breakdown, instability if you go too far posterior. So you must stay in the middle, work anterior. If you go too far posterior, take the lateral collateral down. If you go too far anterior, you're going to trash the pin. Okay, so you do have to be a little bit careful, but there shouldn't be too many. Arthroscopic, you can do an arthroscopic release. It's a slightly different procedure. You're doing a tenotomy. There's maybe less debridement locally of that lateral epicondyle, but again, up to 90% success rates. Use a medial viewing portal, anterolateral working portal, and you essentially come through with a blade and do a tenotomy. It's a slightly longer theatre time. It's more expensive. There's higher risk of nerve injury. And certainly within the patients that I've done this on, and I know speaking to Basil, I'm not sure if Steve's had the same result, but we have a slightly higher failure rate. So there may be not quite as many patients who are happy down the line. That's anecdotal. Okay, it does give you the opportunity to rule out other intra-articular pathology. So if there's a bit of diagnostic dilemma and you're worried maybe there's intra-articular pathology as well, there's synovitis, something else going on, then a scope is a good option to be able to rule that. Other surgical options, there's the option of percutaneous tenotomy. Again, about 90% success rate. Wrist is flexed and pronated, and you do a percutaneous tenotomy under local anesthetic. You can do that with ultrasound-guided, ultrasonic tenotomy, sorry, using a high-frequency oscillation of an 18 gauge needle. I tend to do something similar in my rooms. It's not high frequency, but you just sort of needle that tendon and you feel like you're causing a little bit more trauma when you do the cortisone injections. So you can see that with all the surgical procedures we're doing, you're getting a similar result. And if you look at all of them, they're looking at 90% at 3 years, 90% at 2 years, 1 year. So again, it's sort of within that natural history range. So it's hard then to separate out the success of these procedures with what the natural history of the condition is. Okay. When we look at arthroscopic versus open, there was no difference, particularly apart from the longer operative times with arthroscopic. Open versus percutaneous versus arthroscopic, no difference in return to work. There were a slightly higher number of patients who were pain-free at final follow-up in the open group. All right. So my usual approach to tennis elbow is to try and treat the patients non-operatively for at least 6 months. And if they're really not tolerating it, you do get a group of patients who just are not coping. And then from 6 months onwards, then I would maybe sort of discuss the options of surgery with them. My preference is to do an open procedure, small incision, quick operation. But I do always warn the patients that it can take a long time. And we say most of them will turn the corner between 3 and 6 months, but it can be 6 months to a year before they stop noticing the the pain in the elbow. All right. Okay, so that's tennis elbow. What are those?
How are you going to treat the tennis elbow? Wait a minute. I'll make you a room. The patient now, we're going to treat it.
Prof, I think, like the Plessis said, counseling the patient with regards to the condition is very important, and then I'll do the same.
Well, you're going to counsel.
I'll tell them that there's no evidence that the surgical within.
So I got severe pain. Yes, I've tried anything pain. I can't even shave it anymore.
Can't sleep, wakes me up.
No.
Well, I think counseling them and telling them about the natural cause of the disease and
I don't care about the natural cause. I'll sleep at night.
Yeah, Prof, you're basically forcing my hand to operate, but I don't think.
I'm forcing it.
Yeah,
Not to operate.
I would start with conservative treatment. I would do non-steroidal, do physio. It makes absolute sense what you're saying. And
The problem is most patients come to you after already having tried some of that.
yeah,
And they're frustrated. So by the time they get to you as an orthopedic surgeon, not all of them are looking for surgery, but they're looking for you to do something.
yes.
So what you're going to do?
So then I would give them steroid injection.
Yeah.
Yeah.
So I think that we.
The American says you should not have steroid injections. I know people, I checked it this morning about that. They mustn't have a steroid. They don't use a steroid with the American.
Yeah, it makes it a bit more difficult, I suppose. You have to back it up with literature that you really.
You're a useless doctor. I'm going to go find somebody else. You're going to give me some advice. This is what you're going to be faced with. It's one thing listening to what everybody tells you and stuff. So the person's going to be sitting there and going to tell you, and he's going to tell you, I thought doctor before. I checked it. You must, what are you going to do? I've got pain. One sleep, I've tried anything now. And then physio's cut. What are you going to do?
Yeah, well,
You say, you're going to say, listen, I'm going to give you a quarter and a shot. Can they give you 4 to 6 weeks relief? There may be long-term problems that are affected and can affect your growth and whatever, but it will take your pain away. You'll be sore for a day, you'll coast. If you like the homeopathy type thing, we can give you your own injection. That's what I'm offering now. You can decide if you want PRP, you go read about it, go look at it, and you can have PRP. The brace helps for a certain number of people. Go get a brace, if it helps, you wear it. It doesn't adjust your record. This is what you're going to tell them. You can't sit there and say, oh, well, I'm going to counsel. You're going to say, well, I mean, and every time you see a patient, you must have a constructive process of going. I mean, we listen to the lectures, you listen to them. You can't, you've got to be able to say, listen, this is what I'm going to offer you. And you must, you can tell them all the evidence, but they don't want to hear that. Google it, Dr. Mayo doesn't use it. You can tell it. The cortisone helps. If you don't want a cortisone, the cortisone will take your pain out. The PRP will make your pain worse for 10 days to 2 weeks. But maybe there's a slightly less recurrence rate. If you want them up and then they're off, then they're out of it. You say you want that up, they're out of it until you've been there a couple of times. But you say that if you have an op, you've got in 3 to 6 months, you've got a 90% chance. If you don't have an op, you've got a year to 18 months. So you let them make the decision, but you can't just say, I'm going to counsel them, and you've got to be able to tell them straight. And they want it within 5 minutes. So you say there, you say you may be right, but these guys are all selling the product. The most recent literature says kneeling is better than cortisone. The physio kneeling is better than cortisone. So you've got to give them a constructor, otherwise you're going to lose your patients. And you're not going to treat them. You have to treat them. I mean, the world, I won't mention a couple of international cricketers that I've seen and a couple of different opinions and stuff. They all go down this and they keep going to the PRP, and they got PRP with local, which kills all of PRP. So in fact, there's no benefit. And they come home with a pin pulse because the guy's injected the wrong place. Walks off triggered several years ago. You must be confident you know what you're doing and tell them this is what it is. Now I'm going to give you a cortisone. These are the guys. You've got really bad, have a cortisone. This is the PRP. When you come back, you've got pain, you can make a decision. Anti-inflammatory yourself. You can try some physio, you do the exercise program. 18 months, you're better. If you don't want to wait that 18 months, we'll do an opt, but 90% you're better. You can't just say, oh, well, the literature, when you read, and when you're reading the literature now, you must make a clear mind, this is how I'm going to treat you today. Okay? So, that's the one thing I listen to the lecture, sorry, the philosophy, but it makes it very difficult when you do. You say, in the exam, you can say, I'm going to counsel them, but I'm going to hold them in the corner because it gives them forward. They can go talk about PRP. Just in the exam, you're not going to get it, but I'm just saying that's what you need to do. Every time you read something, and every time you see a patient, you must have a constructive approach how you're going to do it. And that's your approach. It may be wrong, but it's still your approach. Okay, there's no point saying, oh, well, JP said that the meta-analysis doesn't work. Just, get it. Just tell it. Meta-analysis don't work. But you can try, these are the options you go. I'm going to give you a call then, because I believe that it'll be before you sleep, and you can think about the other one. Yeah.
Now, you develop a story around each of the different conditions when you start seeing patients with these conditions. And you sort of, because you've got a half-hour slot to be able to take a full history, examine the patient, and give them the treatment. I agree with you that the education of the patient is important, but it's got to be a constructive thing where you say, this is what we're going to do. And it's also, you read your patients. And there are some patients who literally can lift nothing up. It wakes them up at night. You're not going to tell them that they must go and take some, Voltaren and, see you in the morning. So they're the ones who are going to want an injection. And then the braces as well, you go through that and the wrist splint and that brace. So I think it is useful to speak to them about that. But each patient, whether it's tennis elbow, whether it's frozen shoulder, whether it's a cuff tear, you have your little spiel that you dish out to them. And you just, you get used to that.
There's the one cricket is not South American. I mean, they've tried everything done. Everything to be mentioned has been done. Everything. And eventually they said, listen, stop pissing around. Either an operation for 1 month off. Plan. For 4 months off, that's what you need.
So that was one I was 10 to 18 months. Is that with activity modification? If you get a professional tennis player, it's stopped.
So we're talking about cuff tear now. We're the top 10 biologists in the world. So the question that one person said, how long do you get them all what you get in the quarter? And he just looked at it and said, no, 3 days, 4 days. But everybody used to say 2 weeks. It actually makes no difference. You just want to take that day away anyway and get them big. So I tell them if your pain's gone, you want to go play. But your pain returns, it's your problem, not mine. Their decision what they want to do. You don't know enough about it. If you do PRP, how long do you take it off? And so it becomes a group. You just got to, I mind you must take your contract. This is how I'm doing. This is how I'm going to treat the patient. And be there. You'll keep your patient. Understand if they go to another person, I'm going to say, oh, the doctor didn't offer me anything, just told me some stretchers and front. I said, no, here's a corner, the pain's gone. I said, sure, 2 days later. This is an after the doctor. But then they'll sue you at the man. Okay. Why does one people repeat cortisone?
Also to the local side effects of the blue band, they're not like the depigmentation of the skin, first of all.
Now because they Mayo Clinic sees that's a collateral instability problem. That's because the Americans put it in the wrong place. That's the first thing. And secondly, they give them too many. So if you practice decent medicine, you're not going to put it in the wrong place, one, and you're not going to get it. I've seen one lateral collateral, but I can tell you what it was a missed lateral collateral problem, not from repeat courses. How many of you seen from repeats? No, the man they've seen about 5 or 6 and not that bang. Heard Marty says, no, give them a fucking cortisone. Give them a cortisone. So they operate over 3 months. You don't get better, Marty. You don't get better 3 months, you're not. And maybe he's right. You don't have to have an 18-month waiting. I mean, an 18-month return to play. Just know what you want to do when you read the script, know what you want to do. Okay, sorry, let's take it out.
But you do also have to be able to explain why you don't want to give PRP or autologous blood or whatever it is. You do have to know a bit about them.
And that will be banned. They have to have 2 weeks from a cortisone. They have to have a drug exemption form, and And now they need a 2-week washout period, otherwise you cannot get, we used to get steroids. And it's been banned now. I only found it out about 2 months ago.
Is it seen as performance enhancing?
Yeah. So there's so much conflict at the moment that they're banned. You've got to take drug exemption and then there's 2 weeks washout period. They can't play with them.
Okay. Sandpiper, it's actually a common sandpiper. So if you only know the common sandpiper, you're only going to see the commons. You're going to miss all these other little guys. I think Roche sandpiper, curly sandpiper, wood sandpiper, godwit, greenshank. Did you even know there were so many different birds? So that's the problem. If you only know about the tennis elbow, you're only going to see the tennis elbow. So you have to know the rest of the differential diagnosis around the lateral side. And there's quite a long list of different things that this can be. So we're going to go through some of these now. And again, with the upper limb, always exclude cervical radiculopathy. Sperling's test, and Sperling's test is not positive if they just have pain. And it's got to reproduce the pain in the distribution that you. Okay, so posterolateral placas. This is a fringe of synovium that protrudes into the joint between the capitellum and the radial head, and it catches in extension. So it's a bit of a diagnostic dilemma because in one series of 24 cases, none were referred as posterolateral placa. 80% of them referred as tennis elbow. So this was the group that were confirmed posterolateral placa. See that there are problems with that as well. So they often present with more of a mechanical symptom. So there's the painful snap and extension, a tender in that posterolateral corner. Sometimes the range of motion is limited, so they can have limited extension with pain on passive extension. Clinical tests are relatively non-specific. So we don't have a lot of reliable diagnostic examinations. But the posterolateral radiocapitellar placa test was shown by Park to be 83% sensitive and 87% specific. Does anyone know what that test is? Don't shake your head in the corner there. You do know what that test is, because I did that test on you. Back in the old days. Why is it not playing now? Make this thing play. I don't know why this isn't playing now. You remember this?
Not yet such an okay. So in that posterolateral corner, so you feel in that posterolateral corner, the idea is that you're engaging that fringe, pronation, and you flex it up, and you feel a click or a pop as it goes into that position. So that's supposed to be the posterolateral placa test.
No, why the video is not playing. Oh, there we go. I just had to press. Okay, so pronation, pushing in that back corner there. And you flex up and there should be like. Okay. So the MRI is supposed to show this low signal band with more than 3 millimeters of thickness on the FATSAT T2 images. But there's a very high number of false positives. And one study showed that it was present in 98% of normal elbows. So you can see that this is not a straightforward thing to diagnose, even with an MRI scan. But I think if your clinical findings support it and you see a big placa, maybe you've got a little bit more evidence. And that's it sitting in the back there. And I think here an intra-articular cortisone helps not only from a treatment point of view, because it might bring the swelling of that placa down, but it also helps from a diagnostic point of view. If it's in the joint and the pain goes away, it's more likely to be an intra-articular pathology like a placa. The arthroscopic debridement of these, if they fail conservative treatment and it does come to surgery, arthroscopic debridement generally has pretty good results, although there are no large studies that can conclusively say that. And there's no real consensus of it on the timing of surgery. So how long do you give them before you say, listen, it's time to go and have an op? Some papers voice concern about developing erosive changes in the radial head as a result of these plica's. I haven't seen that happen, but that is something that is reported in the literature. All right. It's not necessarily degenerative, so it's not part of a sort of an arthritic elbow. It's more, I think, related to overuse and just inflammation of that synovial fold that sits in the back there. And that synovial fold is probably a normal thing, but it becomes symptomatic, and then we need to do something about it. The difficulty is we don't really have good, reliable tests to say, when is it a problem, apart from the clinical findings of pain in that posterior corner, and maybe a positive injection test that will tell you that it's intra-articular. And then if it's not settling down and those intra-articular problems persist, then you go and look in the back, and then arthroscopically going, but see if
you could find it on any
so it's more your sort of middle age groups. You're not, I don't think, going to see it in the adolescent patients, and you're not going to see the sort of older patients with degenerative elbows. Then you're likely to have posterior impingement. All right, radial tunnel, this is the posterior interosseous compression that we were talking about earlier. Again, it presents as more of a diffuse proximal forearm pain. So it can be related to the lateral side, and patients will often complain of lateral sided pain, but it's a more diffuse area over the common extensor muscles rather than point over the lateral epicondyle. There's no weakness necessarily involved and no sensory alteration. So it's a condition of pain. And it's a diagnosis of exclusion. So there really no radiological, electrodiagnostic, or pathophysiological findings. So if it's not tennis elbow, it's diffuse. That's when we start sort of. It's caused by intermittent compression of the posterior interosseous nerve as it runs through the supinator. It's anywhere from the radial head to the inferior border of supinator that this compression can take place. And there are a number of different points. There are fascial bands proximally, radial recurrent vessels, ERCB fibrous edge, arcadophores, and supinator fibers can all lead to the compression. Clinical signs, again, Maudsley's test, middle finger extension, and pain over the extensor and supinator muscle. So if you compress in that area, generally they're not necessarily tender over the lateral epicondyle, but more of a sort of compression over the muscle. Bellies are painful, and resisted supination with the elbow and extension, as opposed to Jurgensen's test, because you are taking biceps out as a supinator, so you're relying purely on the supinator. MRI is usually normal. They do talk about signal change in the posterior interosseous nerve or denervation changes within the supinator to varying degrees, but you can see only at about 50% in that study. But what it does do is it excludes other pathology. Again, as we saw with the tennis elbow, you've got to be careful though, because there's quite a high proportion of patients who have normal elbows who will show changes in the common extensor insertion. EMG's got very poor correlation, only 9% positive in that one paper there. And you can use an injection test to differentiate from other diagnoses such as tennis elbow. So they go and find the nerve, the ultrasound, and you put a bit of local anesthetic in there and see if the pain goes away. Obviously warn the patients they're going to get a wrist drop if you put local around the pin. All right, and treatment, rest, activity modification. So there's often a provocative position or provocative exercise that may bring it on. So you try and change the activities. They can wear splints. You can try physio, try a cortisone injection. This group found that 60% of patients were pain-free after 2 years with the cortisone injection or surgery. And you speak to some of the hand surgeons and they get to a point where they use surgery as a diagnostic tool. So you're not sure, you go and release the pin. And there's no consensus as to when the timing of that should be. How long do you give them of non-operative treatment before you go and do a pin release? These were, where did we do this? I think we did this in some. So you do a trans brachyradialis approach. through the muscles, open the supinator, and there you can see the pin on that side. It's not showing my cursor. Right on the right, that band running across in the supinator. Okay, distal biceps. So the biceps can generate a lot of pain, and we see a lot described about around the proximal biceps, the tendonitis proximally, the ruptures proximally, but there's very little that's written about distal biceps tendon pathology. And it's generally only mentioned as a spectrum from strain to partial rupture to complete rupture. And one of the first papers that looked at the conservative treatment of distal biceps tendons and identified this group of patients with no injury, but with distal biceps pathology, was this paper published by Michelle Marie, and Basil, and everyone. So that was published back in 2011. And this group of patients, so these are patients with a distal biceps pathology without an injury. So they have quite diffuse upper forearm pain, pain in the cubital fossa. They may have pain in the posterior aspect, so in the dorsal aspect of the forearm in full pronation, because as you pronate, you bring the insertion of the biceps into the posterior, and pain with activities involving supination. Clinical signs, they're often very tender over that distal biceps. Again, tender over that posterior forearm in the pronated position, and pain and weakness with Yergenson's test. And distally with Speed's test. And if you're uncertain about it, investigations can confirm it, and the ultrasound can often show fluid in the biceps sheath. You may see partial thickness tears of the distal biceps, and the MRI scan, particularly with this FABS view, so that's flexion, abduction, and supination, can show you the entire length of the distal biceps tendon. And it's quite a useful view to use to identify partial tears, synovitis, or even full thickness. Treatment is generally with, we use cortisone injections. Again, there's some controversy around whether we should be using cortisone or not. Injections these days we use using ultrasound. So you hold the probe transversely to the radius. You start at the radial neck, and you can see on the left-hand side that nice round contour of the radial neck. As you go distally, the tuberosity flattens out. So the screen on the right where the arrow is coming down. As you see that flattening of the radius, you know that's where the bicipital tuberosity is. And you just inject out of plane straight down onto that. So you on bone and you infiltrate the local anesthetic cord and cortisone there. So if you're on bone, you're unlikely to be injecting into anything you shouldn't, and often has quite good results. So this was that paper that now there were 24 elbows, 20 patients. 11 were referred without a diagnosis or as tennis elbow. So again, going back to that same point, you see a lot of these patients with other conditions referred as tennis elbow. 22 had cortisone injections. None of them ruptured. 40-month follow-up, 16 of 22 had complete resolution of their symptoms. These were patients who had symptoms for less than 8 months prior to having the injections. 5 of 22 had symptoms that persisted for 6 months or required modification of their activities. There's another paper, similar numbers, and they found that 16 of 22 responded to non-operative treatment, which is anti-inflammatories and cortisone. Their indications for surgery were 6 months of failed conservative treatment. Or if they saw a partial tear on MRI scan, they felt those patients had a higher chance of requiring surgery. The acute rupture is obviously fairly easy, well, should be fairly easy to pick up. The history of trauma is not always high energy. So often you find that it relates to forced hyperextension. So we see in a lot of the squat plates snapping into extension, or the arm being pulled against the direction that the biceps is contracting. So catching something that's too heavy, those are the sort of injuries. Often there's a Popeye deformity, and patients will describe a pop and they feel the whole muscle pull up proximally. The hook test is quite a sensitive test for that. Which side do you do the hook test from, lateral or medial? And why? Which side are you hooking from? From lateral, why? You've got lacetus fibrosis. Well done, yeah. Lacetus fibrosis, okay, on the medial side.
Well, that's just because it gives extension with the biceps. Aids to other ability. What happens is when you contract in the bicep, tension your pressure of the flexor muscle so you improve the strength. That's the theory behind why you have a lassitude. Plus it gives them support and it changes the direction of the bicep. So, but the thing is, as you want it, you need the strength in there and it actually tensions your pressure to improve. And that's why sometimes you don't get too much retraction of the lassitude intact because you can't spring right up. So you can actually miss a rupture. But that's why you must be careful because we just had a peg major that thinks you, so it was missed, and you don't want to miss this either. There's another reason why you might miss a ruptured bicep. Why? You didn't listen to our talk last year, Congress, did you? Did you at the Congress last year? You come listen to our talk. Why do we have two biceps? Distally, we actually orthopedic a single tendon. We actually two tendons. You can rupture one head under the head. Okay. It's very reported, but I mean,
Actually did
it hasn't been reported now. So you can miss one of the rupture. Okay.
All right. So you can do investigations like ultrasound, MRI scan if there's doubt, or in partial tears if you want to confirm it. So if you feel that you've got a negative hook test, the biceps is down there, but the patient's still very painful and there was a significant injury, an MRI might show exactly that one of the heads is ruptured or that there's a partial rupture. But this is primarily a clinical diagnosis. You don't have to have an MRI or an ultrasound to confirm a full rupture of a distal bicep. Treatment of the acute ruptures, you discussed conservative versus surgery. We tend to sort of do a little bit more surgery than conservative treatment. Once you've told the patients and educated them around there, they tend to want the surgery as well, and surgery has pretty good results. It's different to a proximal biceps where you may not notice the function. They do notice the weakness in supination, and you can see that when you examine the patients. And once you show them how weak they are in supination, they tend to want something done about it. But there are a number of people who leave it alone. There are a couple of orthopedic surgeons who've never had theirs fixed and they carry on doing what they want to do. So you certainly don't have to have surgery. And you often see this very tendinotic looking tendon. So it's very broadened and inflamed. It's very, always say that normal tendons don't rupture, and they often really do look very inflamed. Whip stitch around it, and then this is just the surgical technique that I tend to use, and drill it into a 7mm hole in the radial bicipital tuberosity. We plug it in there with an ender button on the other side and sometimes an interference. Okay. Right. Olecranon.
There must be a reason. If you go to court, they can ask you why you operate.
So, like Dr. Plessis mentioned, are they going to have significant loss of motor function in supination?
What's significant? Significant to me, significant to you.
No, it's like to your host. As I said, you've got a 50-year-old gentleman or a 50-year-old chap. It's still, that's.
I don't know, 90-year-olds are decathletes, world decathletes. The winner, the one in Brazil.
Yeah, it comes down to that's when you pass back to the patient.
Yeah.
He's very conservative.
Yeah, but what's significant? He might say, listen, I can use 20%, I can use 30%. So what is significant? If you lose a long-headed bicep, what do you lose? You lose a long-headed biceps, approximately, what do you lose? Don't lose elbow flexion strength. You may actually lose forward elevation strength in the shoulder, but nobody's really tested that. But you will lose 5% of supination strength. So you lose supination strength. So most people can sacrifice that. You use a distal bicep, what happens? You know, step in.
I don't know. Just tell them that.
Yeah. Our flexion. It's a much bigger sacrifice. Sorry, you lose 50% of your
Supination. Yeah.
And you lose 70% or 50% of what? 50% of what? So they must know 50% is quite important for some people. So if you're a big surgeon and you're trying to do knees and doing stuff, you don't want to lose that strength. So it is actually important for some people. So they must know what they're going to lose by having it, because the problems of surgery are, what's the biggest problem? posterior interosseous nerve gone. So now they must know they're going to agree 50% of this or 100% of this. Now you're going to say, oh, let me just think about it, and it happened. So we've not settled on that.
Yeah.
So you got to, when each time you're assessing the patient, they must understand the problem. And the other risk is synostosis. You have a synostosis means another op, you lose some strength and so much, it's not always guaranteed and stuff. And very often the synostosis involves your biceps, you actually lose the bicep number. So not that I have not said one.
But the synostosis is more likely with the two-incision technique, so higher incidence of that. And we tend to do most valves through a single incision. So
I say, I'm a 55-year-old. When I play a bit of paddle, which right of them getting on paddle. And that's what they say. You must understand it's something operating on what you want to achieve and what the downside is complete pinball is a problem. You just understand every time what you're doing, why you're doing it.
There is also the issue of cosmesis, and we tend to gloss over it, particularly working in the state, but there are patients who really don't like the way it looks, and as much as you tell them, listen, it's not going to be a problem, you can do what you want with it, but they just do not like the cosmesis of a biceps that's sitting up here. And that is something to discuss with them.
I'll give you some more advice. Don't judge that person because you think, okay, it's not going to make any difference to that person. Don't presume that, because there you will be gobsmacked at how many people will say, no, can't look like that. And they have tattoos everywhere, half the things are ruptured, they've got sunspots everywhere, but they don't want to think. And then the other person who's much more functional, they want to go karting, they don't care. Just don't say, oh, you don't worry, it's just a cosmetic.
Yeah, it is important. It's important to some people. All right. Okay. All right, so olecranon impingement. So there's a posterior impingement in the olecranon fossa, so you get a buildup of bone or soft tissue in the olecranon fossa on the posterior trochlear. So as the patient's going to extension, they're going to have impingement there. And this can be as a result of a number of different things, either primary arthritis, repeated hyperextension trauma, valgus extension overload. So all of those sort of repetitive extension injuries, or from an arthritis in the elbow, and you get these little builds up of osteophytes in that posterior lateral or posterior medial. They present mostly with pain and extension. They can be tender in the olecranon fossa or on the posterior lateral joint line, and there's pain in passive extension. Often they have a physical block to extension, not just pain that's stopping them, they can't go any further than that. And this was a group of patients that I think Stephen Basil looked at a while ago. And of all the patients referred, so 8 were from the practice, and of all the rest, only 2 were referred with the correct diagnosis. All the rest were referred with tennis elbow. There's a better prognosis with non-operative treatment. So they got more chance of responding to conservative treatment if the duration of symptoms were less than 6 months. There's a less advanced fixed flexion deformity, under 10 degrees, and an absence of changes on x-rays. So if you can see the osteophytes on x-rays, then there's less chance that they're going to. And in these patients, if we do go and operate, let's see if there's. Why is this not playing? I don't know why my videos aren't playing. There we go. Maybe I'm clicking. This is looking arthroscopically into the posterior aspect of the elbow. So that's olecranon fossa on the right, and tip of the olecranon that you can see moving on the left-hand side. And you just come in straight from posterior with a burr, and you shave any osteophytes on the back, and then come down that posterior.
Just a lot of people get misdiagnosed for things you've got to examine the patient, you've got to take a history. And sometimes it's difficult. So 50% of these patients, not in our series, but look at the literature, have OA, and they get missed as an OA patient. So if you've got an OA patient, you must be careful. Maybe the infection works as well. Examine them, check that they're not, it's not just. where you're going to take up, and if you miss it, and I've had to revise several patients who had surgery because they missed the CT scan. Taken out what they can see on the X-ray or something, or maybe even the MRI, they actually must delete it. Take it away,
Medial side.
you increase the instability.
I'll go down the medial one, which I sort of mentioned. Yes, the CT does help you to plan so that you know where to go. If you see a big osteophyte in the medial gutter, careful of going there arthroscopically. All right. Where were this? So if you look at the literature, the results of posterior impingement arthroscopic treatment, the results are pretty good in getting patients back to where they want to be. So this is posterior impingement, 97% return to play. In the valgus overload patients, as Steve was saying, there's an association with medial ligament. There can be an association with medial ligament disruption or laxity. And then you're going to exacerbate those symptoms if you take away the posterior osteophytes. So those posterior osteophytes are in essence sort of contributing to stability now as the medial ligament goes. So you've got to be aware of that and got to pick up medial instability in those patients. And then osteochondral lesions, just a couple of brief things here. So these are injuries that disrupt the cartilage and adjacent bone, usually in the capitellum, but we sometimes see them in the radial head, olecranon, and trochlea. And this is not Panner's disease, which is the whole capitellum. This is a sort of specific osteochondral. Often in the adolescent population, throwing athletes, and it's again from repetitive valgus overload to a poorly vascularized or immature capitellum. These patients have posterolateral elbow pain. They may have an effusion. Sometimes there's signs of a loose body, of locking or mechanical symptoms or stiffness. And the prognosis depends on the size. So if it's more than 50% of the capitellum, on the area that's involved. So if it's the lateral margin, then the prognosis is a bit worse, and the age. So once they go beyond skeletal maturity, it's more difficult to manage them successfully. And there are various grading systems looking at X-ray, MRI grading systems and arthroscopic systems. I'm not going to go into now, but it's worth having a look at those and knowing about that. And sometimes it's a barn-door diagnosis like this, where you can see a loose fragment that's flipped in the front of the joint and the defect come from. And often it's a little bit more subtle, where you just see it as that lytic area in the capitellum. And that's obviously a sort of earlier grading. The MRI scan is useful here and also helps to grade it. So if you're seeing fluid that tracks underneath it, then it's telling you loose and it's a higher grading system. And then treatment is conservative in the early stages, and surgery is there for failed conservative treatment, or once there are mechanical symptoms and loose bodies, if there's fragmentation, or if there's a restricted range of motion, and in the older patients in the when there's a closed capitellar growth plate. So the younger patients, we tend to sort of try and modify. These are sometimes some of the most difficult patients to manage, because they've got this because they are highly competitive, driven adolescents with parents who are equally driven, and to try and tell them to stop doing their gymnastics or stop playing their cricket is often very difficult. This was just that patient that I'll show this. He was a 12-year-old cricketer, and you can see the size of that lesion. He had mechanical symptoms, obviously, around in there. So you can see, we just took that out. He's done quite well with that. Now you've got to make it a bit bigger. You just put an artery or something in just to widen a little bit so you can pull it out. But if you go and look at the literature around this, there are a lot of studies that go and fix these with little condyle darts or small screws or various other things. And I've never fixed one. I've only removed them. I think if that bed has got sort of fibrotic tissue in it, we might go and pick it or braid it, just get a little bit of healing to come through. But Steve, I don't know whether you've gone and fixed those.
I mean, we see very few compared to the Japanese.
Yeah.
And the Japanese are the biggest series, and they say over 70 should be fixing them, it depends on your grading. Once again, it's the age. If they're under 13, 14, growth rates are right, then you can try to get them again and try. Once it's loose, you either fix or side, and they recommend more than a centimetre you graft them. So they'll be grafting for their fractions. So they're the world leaders. You sort of got some. We've taken out some big ones, JP taken out some. Most of my patients are, and the young ones, I've just drawn them, the early stages, so they're not loose. I've got a couple of I've just drawn with the KY on posterior using ACL check. I've not had one that's come loose after that. I did one probably a year and a half ago, but I don't think I've even done them. I think maybe I've got about 5 or 6. There's very few, and I could ask the guys for advice, and there wasn't anybody that more than that.
I think Basil talks about the one that he had to rescope later for something else, and it had completely healed over, and he had just removed it.
He left it with his body in.
Yeah, I think that was
So
really
when he went back, you couldn't see where the just regrown the body goes. So we've only debride, or I've drawn the early stage ones I've drawn. And I have an international climber, adolescent, who had a loose body and osteochondral defect, and she was losing range of motion. So Bernard Murray reckoned if you're losing range of motion, you must less them into that account in the top rate. Once they're losing range is the problem. And she declined surgery, and she's now 5 years later. She has almost a full range of motion. She has no rocking, no symptoms. The loose body's still in there, and she's sort of got a university in the States where she's been flying. She's back now, still in Roche, I know. And she happens to be my neighbor, so I know exactly what's happening with her elbow. So, and I tried to convince her to surgery and declined it. And she's done very well. So, you know, she's not symptomatic. You can watch them for a while. See, the loose body. It's not like a knee. You've got a loose body in the knee. Not the same or in the shoulder. But the elbow is very hard to get in there unless it's in that posterior fossa. It's more likely to be a problem.
So no oaks yet, Prof.
Sorry?
They're not doing oaks yet for these lesions.
No, they do oaks.
So Japanese do the grafts, yeah.
Will do a fresh kind of graft. And they actually, you hyperflex up. Remember, it's very often the capital is the back there. And one of the diagnostic tests is actually, you get them up and you press them. And if you don't have an X-ray and stuff when you're examining the patient, so you look very clever if you say it's not, I think you may have. But you might get a suspicion of 14 putting on over throwing athlete or overuse athlete. Think of the osteochondral defect. No kid has a tennis elbow.
Yeah, we're going to get to
And you know how many kids are you talking about that? Yeah.
Okay.
You see a kid with tennis elbow that got what? Before JP did this, you get the answers right. Huh?
They've all heard this one. Someone listens to one thing. You listen to one thing.
What else?
What else?
What else is your opinion? Yeah, so they can have an osteocondrosis or a stress fracture. And overload, lateral overload from the stress fracture.
No.
Okay, so you have venous hypertrophy, don't get golfers elbow. It's stress overload, and depending on the lateral side, it's stress overload from stretching out MCL and getting overload osteochondral, and that'll have a hot MRI. No kid gets a tennis elbow. You know how many people I get the tennis elbow and it doesn't happen.
So it's quite similar in a way to the way we talk about shoulder examinations. You can tell you've got a good sort of 70-80% chance of making the correct diagnosis when the patient walks in. You find out how old they are, because your age stratifies what conditions you're going to get, and it's quite similar with the elbow. And then just to mention inflammatory arthritis, there's obviously a lot on inflammatory arthritis, but just specifically to the elbow, that rheumatoid affects 20 to 50% of patients in the elbow within the first 5 years, and 5% of rheumatoids have an elbow involved in isolation. So 5% will present with the elbow being the problem. So you must just keep that as a diagnosis in the back of your mind if things aren't fitting together. You see a patient with a big effusion, a history of inflammatory arthritis, loss in range, and it can also be related to enthesopathies. So patients with bilateral tennis elbow, tennis and golfer's elbow, just keep that in the back of your mind, and it might be worth just doing some blood tests on those patients that aren't fitting neatly into a box. In these patients, if their medical management fails and they getting persistent synovitis, you can go and do an arthroscopic synovectomy in 2/3 of patients. It improves, but there's a fairly frequent recurrence in synovitis within the first 5 years. All right. In loose bodies, we get from lots of different things. You've seen them from the osteochondral defects, but you can also get it from arthritis, from trauma. Those posterior impingement osteophytes can break off. And their patients present with intermittent symptoms, blocking effusion, loss of extension, which may then resolve. They sort of fine again. And arthroscopic removal for loose bodies works really well. You have very happy patients if you go and you find it and you take it out. Leave a few in there, then you. In the golden plover, the rare bird. So most of you have heard this case report, so I'm going to go through it fairly quickly. But this is just to illustrate Steve's point. Kids don't get tennis elbow. So this was a 16-year-old who was sent to me after a press-up competition, boarding school somewhere. He had 2 cortisone injections, swollen, effusion, no movement. You must examine your patients. Not everything is a tennis elbow. X-rays were normal. He was pyrexial, raised CRP, ESR, normal white cell count, and he had the septic arthritis with osteitis that extended all the way. Why did we get an MRI? Because by the time you see a 16-year-old in private that's been injected 2 times with cortisone, who's got parents that are talking about sending him to the Mayo Clinic with a big swollen arm, and you can get an MRI, you get an MRI. Okay. I actually saw another patient recently 2 months ago, very similar story. She was 14, I think, who was referred down from East London, also had 2 cortisone injections. She had a year of pain and came in, not with the sort of septic arthritis type elbow. She had range, but she had a swollen elbow and loss in range. So she couldn't get into full extension. And I unfortunately couldn't find her pictures and things, but she had an osteoid osteoma sitting in the olecranon fossa. So there are these uncommon things, and when patients are not fitting neatly into a box, you must just start to be able to think of those rare conditions around the outside. Don't jump to tennis elbow every time. Okay, so young patients don't get tennis. So most patients are referred with tennis elbow, and many of them will have it. Can usually be treated non-operatively. Look out for other conditions. If you don't know about them, you're not going to find them. Okay. That's the lateral side. Strength for the medial side.
You sure you want to see this contract, or do you want to bring it to another talk?
It's certainly, it's not as long. It's definitely not as long as this.
You're showing the sleeve there, are you showing you've got short biceps?
He's only in my throwing. He's only in my throwing shoulder talk. Okay.
10 minutes, Jeffrey.
10 minutes. All right.
10 minutes.
We'll fly through it.
Have you learned anything tonight?
You've learned what a golden plover is.
We didn't send you any literature to be overloaded too much.
Birds of prey.
Okay, so medial side. It's common than the lateral side, but on the medial side, there's a lot of overlapping pathology. So it's not necessarily as distinct as tennis elbow, posterior impingement. So there's a lot of overlap. It's a lot of different birds altogether. Okay, so we've been through some of this. I'm not going to go through instability. So there's a little bit less to go through on the side. The important thing is knowing about the anatomy on the medial side. So you've got these 5 tendons of the common flexor tendon. It's the sort of most commonly affected area. The pronator teres is the most commonly affected of those tendons. And remember, the ulnar nerve is sitting just behind him, running into the 2 heads of the FCU. When we look at the anatomy, it's a little bit different on the medial side. Your ulnar nerve, remember, sits just in that position there. What's that? That's your medial collateral ligament lying just underneath it. Okay. And over there is where your common flexor tendon sits. So they're sort of quite intimately related. So pathology of one can mimic the others, and you can get coexisting pathology. All right, so this is what it looks like in real world. So that's the ulnar nerve, obviously. That's your medial epicondyle. The hand is to the right. and that's where the medial collateral ligament is going to sit. So they're all pretty close to each other. So with the medial elbow pain, you're not trying to distinguish between those different anatomical structures as to where the pain is being generated. Pain can be directly over the medial epicondyle. There can be quite a lot of distal radiation of the pain. You want to find out about the onset of symptoms. So is this a slow development as in an epicondylitis, or is there trauma involved? Is it an MCL injury or flexor pronator mass avulsion? And is the pain primarily with wrist flexion in day-to-day activities with grip strength, or is it with valgus load as they're sort of pushing themselves up out of a chair? Is there associated ulnar nerve symptoms? And what are their sporting and occupational activities that may have fed into this? Then Sperling's test. Okay. Very important when you're examining the elbow, particularly post-traumatic, even if you think it's mild trauma. Look at the medial side. If you've got significant medial-sided bruising, you must suspect a medial collateral ligament injury. Look at the carrying angle as well for chronic. The point of tenderness helps to distinguish where the condition is. Is it epicondylitis, where you're going to be tended directly over the epicondyle or over that pronator tendon running slightly anterior, or is it more related to the ligament, which can be a little bit posterior? So palpating carefully, you can distinguish between the areas that are generating the pain. Range of motion. If there's limited extension, it's the same story as the lateral side. Are there posterior osteophytes? Is the patient doing something that makes them prone to valgus extension overload? Is there intra-articular pathology, loose fragments, OCDs? Assess the ulnar nerve during the range. So it's a dynamic thing. You're looking for subluxation, looking for a snapping triceps, and are there ulnar nerve symptoms in sustained flexion with the wrist in extension? So that is going to tension the ulnar nerve and may reproduce some of those symptoms. Examining for instability. That milk test was originally described with the patient doing it themselves. I've tried to get you guys to do it, and Fernand's the only one in the picture here because no one else. So you're holding yourself in that position of valgus load, and then the physician palpates over that medial ligament. Okay. The moving valgus test, you do it yourself. So you're holding the patient's thumb, you're holding them in that valgus position, and you can move through a range of motion while palpating over the medial collateral ligament, looking for pain in that area. That's as opposed to looking for the medial epicondylitis provocative test for golfer's elbow, where you've got resisted flexion and pronation, or simply resisted pronation with the elbow flexed. I find that's a fairly sensitive test for medial epicondylitis. You're loading pronator rather than all the flexors. For ulnar nerve symptoms, your full neurological examination, sometimes it's fairly obvious when someone's plated the ulnar nerve. And you must obviously all know Frohman's test. You can see that FPL coming into play, and it's weak intrinsics. Okay. The investigations around the medial side may have a little bit more relevance than the lateral side. So we might sort of go ahead and do some more imaging and things with medial sided pain if there's diagnostic dilemma. And this study back in 2010 showed that X-rays, 57% of them had some sort of abnormality with medial sided pain, whether it was calcification or osteophytes or opening under the valgus stress test. Ultrasound can be useful. Epicondylitis, I think I haven't ever used it to diagnose epicondylitis, but the ultrasonographers talk about whether there's tendinosis or whether they feel there's thickness of the common tendons. But it can show you an injury, like a common flexor avulsion, and they can assess the MCL looking at the dynamic stress test, whether there's opening of the joint. Some studies have shown if there's more than 2 millimeters of widening, this denotes instability. And this study said if there's more than a 0.5 millimeter difference between the two sides, that's instability. I challenge you to tell the difference of 5 millimeters in the different sides, but that's what they say. So you can use it to look at the dynamic instability. MRI is obviously the gold standard when you come to looking at ligaments and X-ray avulsions. You can see here that's a complete avulsion of the pronator mass. There's nothing attached to that medial side there. Also helps to rule out other pathologies. So if there's uncertain diagnosis, you can look for your OCDs and stress. There's just a little osteophyte or loose body in the posterior medial corner, loose bodies in the joint. MRI is maybe a little bit more useful here. And then the other thing that it can show you is that's the medial-sided, sort of medial-sided osteophytes there from early osteoarthritis, which were impinging on the ulnar nerve. So that was an underlying cause for ulnar nerve compression. All right, so just going a little bit into the pathology itself. Golfer's elbow, less common than tennis elbow. It's that sort of middle age range, and they say that 80% spontaneously resolve in 3 years. So not quite as consistent or as quick as tennis elbow. It can be a little bit more of a troublesome thing for the patients and to treat, and quite a high incidence of associated ulnar nerve symptoms reported. Caused by partly repetitive eccentric loading and partly by valgus overload, because the common flexors are also a secondary stabilizer, a dynamic stabilizer to valgus overload. So again, you get that interplay between repetitive valgus overload causing the common flexors to become tendinotic and painful. They then fail. They then put more stress on the medial collateral ligament. So you have this knock-on effect that can result on the medial side. And it's less well studied, but we look at it in the same progression as we do for the tennis elbow and other tendinopathies, with inflammation and your fibroblastic hyperplasia, loss of structural integrity, and then fibrosis and calcification. But this may then progress to involve the MCL as well. The goal of treatment is to treat the acute symptoms, so get rid of the pain, then rehabilitate the tendon and prevent recurrence. And we have the same strategy as with the tennis elbow: activity modification, ice, anti-inflammatories, bracing, and then there are a lot of other treatment options that are also thrown around here. I still tend to use cortisone, but you can try shockwave therapy, PRP, and you can find evidence for most of these things in the literature. This was a study looking at the comparison. This was effectiveness of other treatment options for treating medial and lateral epicondylitis. So they tried to do a systematic review for medial and lateral epicondylitis. And the conclusion on the medial side was that there are no randomized studies or meta-analyses that can be. So there just isn't the evidence out there to put together any sort of analysis on what works on the medial side. And find evidence for extracorporeal shockwave therapy, may help in a small group of patients. The literature doesn't really support it, and it's not without its problems. So this is a study showing ulnar nerve neuropathy after shockwave therapy. And the sports physicians are quite keen on this, but if you speak to the patients, it's a painful treatment option, and it's not something that I advise my patients to do. Cortisone, short-term benefit with little evidence of sustained response. So similar to what we find on the lateral side, but it is a quick option. It does get rid of pain, but you warn the patients that it may come back, and they need to look at the rehab as well. And when it comes to rehab, similar principles to the other side: stretch, early range of motion, and eccentric exercises introduced at the end. Along with the rehabilitation is sport-specific interventions. So with golf, it's usually the trailing arm, and you can adjust club length, club weight, strike zone. Tennis is often related to poor forehand technique. So late ball striking, you can change the racket weight, grip size, string tension, all of these things. And this is something that you can get the sports physicians involved in. In terms of treatment, small trials, mixed results, basically inconclusive evidence to make recommendations. So you don't have a lot of support from the scientific literature. And again, similar to the lateral side, you must have a strategy that you go in with. You must have a story you tell your patients, and you must be able to back them. When it comes to surgery, open debridement. So there are some reported cases of arthroscopic, but it's not something that I think you want to go and do arthroscopic. Open debridement, and then varying degrees of common flexor release, epicondyle decortication, microfracture, and then repair of the tendon again. And then you address the ulnar nerve depending on symptoms. And your risks around the surgery surgery. It's the ulnar nerve. There's nowhere it is. Medial cutaneous nerve of the forearm. You don't want neuromas there. And then damage to the MCL, to the anterior band of the MCL. The outcomes in surgery are reported when you don't address other pathology. So the outcomes of golfer's elbow release, of medial epicondylitis release, are not as good when there are ulnar nerve symptoms or when there's an MCL problem. And this was first shown by Mori back in. And then there was this paper that said that maybe it's slightly more successful if you go and do a transposition of the ulnar nerve than if you just do a when you operate in association with golfer's elbow. So ulnar nerve, second most common nerve compression in the upper limb, various points of compression, intramuscular septum, triceps hypertrophy, cubital tunnel retinaculum, Osborne's ligament. Many of you have heard of the Amadio Beckenbach arcade. Anyone? No, no one listened when I gave this talk before. Okay? Yeah. So that's between FCU and FDS. So I think it's worth just knowing those various points where it's going to get compressed and where you would need to release it as you go down. It can also be dynamic compression. So commonly, that's where that flexion test comes from, that it tightens up the retinaculum in flexion. So you're going to have dynamic compression there, and dynamic compression can also be caused by triceps hypertrophy. And other contributors such as diabetes, space-occupying masses, so osteophytes deep in the canal, Anconius epitrochlearis. What's that? Anyone heard of Anconius epitrochlearis? It's a muscle like Anconius, but it's on the other side. Okay, epitrochlearis. So it's an aberrant muscle that sometimes fills the space in that on that medial side and can contribute to ulnar nerve compression or malunions and malalignment of the elbow. McGowan's classification is useful to know because it's fairly straightforward, and while it might not guide management too much, it gives you something to stage ulnar nerve compression on. Subjective sensory, objective sensory and mild weakness, or marked intrinsic wasting. So it's fairly simple. And the teaching has always been the higher the grading, the more likely you are to go and do a transposition as opposed to a release in sight. A conservative treatment, there's a short duration of symptoms, mild symptoms. First you start with activity modification and night splints and educating the patient about what causes it. If they don't respond to that, or if they're more severe symptoms, you decide whether you're going to do a release in situ or a transposition, and whether you're going to do that subcutaneous or submuscular, and in the severe cases where you need to do a medial epicondylectomy. I've never seen one of those, but when it comes to looking at whether you release in situ or do a transposition, I think there's some fairly straightforward. If the nerve is unstable when you've released it, you're going to want to transpose it. If there's joint pathology underneath, so if there are osteophytes or something taking up space in the canal, in a very valgus elbow, you may want to do a transposition. And it is advised in McGowan stage 3 that you do a transposition as opposed to just a release in situ. But there isn't really a lot of evidence to support one technique over another. This was a Cochrane review done recently, which showed that there's not enough evidence to support multiple treatment meta-analysis, and that simple decompression and decompression with transposition were equally effective. And this included whether you were treating impairment of higher degrees, so in other words, the McGowan 3. So they can't show that there's a difference in these groups, but that it is advised that you go and do a transposition with. And then one or two just less common things. Snapping triceps. Has anyone heard of a snapping triceps? Yeah. So it's an uncommon condition which can be associated with ulnar nerve symptoms. Painful snap over the medial epicondyle. The ulnar nerve, when it subluxes, is usually in lower degrees, so it's 70 to 90 degrees, with the triceps snapping over above 90 degrees, about 100. And it is from anatomical variations in the triceps, bony anatomy, or an alteration in muscular dynamics. And in the literature, it's mostly case reports and small series, and treatment is largely non-operative. And when it does come to surgery, it's to try and restore alignment or excisional lateralization of the medial triceps slip. I think it's just worth knowing about the condition as a differential form. In adolescent injuries, Again, medial injuries, there's a whole lot of literature on the little leaguer's elbow and throwing elbow. And these are the younger patients who can develop apophyseal avulsions. Surgery is indicated if the elbow is unstable or if there's more than 5 millimeters displacement. And in the older patients, this results in MCL injuries, valgus overload, and generally we treat those non-operatively unless they're more extensive or very unstable, and then you're looking at surgery, acute repair, or reconstruction with delayed cases. So a very brief overview on medial instability. You need to know more. Okay. But we do sometimes see these medial epicondyle avulsions, and this is, again, a reason that you need X-rays in 2 planes. That's a incarceration of the medial epicondyle avulsion. Does anyone remember how you get that out? Robert's maneuver. Well, valgus supination and wrist and finger extension. Pop that out of there. Okay. All right. So that was a very quick rundown on the medial side. It's less common than the lateral side. There's a lot of overlapping pathology between medial epicondylitis, MCL insufficiency, and ulnar nerves. You want to try and differentiate between those. Advanced imaging may be more useful if the diagnosis is not clear. And surgery for medial epicondylitis has less consistent results than for lateral epicondylitis, and particularly when there's ulnar nerve involvement. All right. Questions?